This presentation focuses on the risk of implant failure. For many years, an important limiting factor in comparing research on dental implant failure was the lack of objective criteria used to define implant success and a clear parameter used to distinguish survival and success. Therefore, it is important to define the different terms used when describing implant failure. Implant success. Successful implants fulfill a list of criteria considered essential for long-term survival. Criteria for implant success were defined by Albrechtsen in 1986 and later modified by Roos et al. Their success criteria serve as a standard for clinical and research purposes when new implant systems emerge. These criteria for success have been adopted and further modified by the International Congress of Oral Implantologists, ICOI, Pisa Consensus Conference. Esposito in 1998 described implant survival as a situation where the implant may be physically present and functioning yet fails the criteria for being successful. Surviving implants exhibit characteristics that lead to eventual loss of the implant. This refers primarily to the state where the implant has lost integration at any time point following implant placement. A few other conditions, such as progressive bone loss or pain, may deem an implant as a failure. Today the parameter of an aesthetically acceptable implant has been added to the definition of implant success and, conversely, implant failure. Classifications of implant failure. There are two commonly used periods to assess an implant failure that relate to the time of occurrence. Early or primary failures are failures that occur during osseointegration or the healing period. Often, this fail is a result of surgical and/or postoperative complications. Late or secondary failures are failures that occur after osseointegration. Usually this occurs during and after the restorative phase. With either type of failure, there is no single etiological factor. Implant failures have been attributed to poor surgical technique, host factors that impair healing, poor bone quality, peri-implant infections, poor prosthesis design, and traumatic loading conditions. Early diagnosis of problems is critical and every effort should be made to treat the problem while the complication can still be managed or even reversed. Lower implant survival rates have been associated with reduced quantity and quality of bone. Herman in 2005 reported 5-year survival rates of implants placed at different configuration of bone quality and quantity. Healthy patients who presented with a combination of type 4 bone and jaw shape class D and E experienced up to 63% failure rate. In addition, Nogueral et al. 2006 noted a 1.93 greater risk of early implant failure in implants placed in anything but type 2 bone. Due to differences in bone quality between the maxilla and mandible, location of implants may be associated with higher or lower survival rates. Implants placed in the maxilla have failure rates 3 times higher than those in mandibular implants. Higher failure rates was also reported by Van Steenberg et al. In 2002, where more than half of the early failures occur in the posterior of the maxilla. Often the maxillary posterior region lacks thick cortical plate, dense medullary bone, and vertical dimension due to sinus pneumatization. Krkanovic et al. In 2014 concluded that the poor quality of bone of the maxillary posterior has been cited as a reason for the lack of initial stability and high early failures. This association between quantity/quality of bone and implant survival rates emphasizes the importance of and prerequisite for bone augmentation procedures prior to implant placement in atrophied jaws. Soft tissue recession may be expected following immediate implant treatment, and multiple factors seem to contribute to the phenomenon. Taking into account the paucity of papers, patients with an intact buccal bone wall and thick gingival biotype treated by means of flapless surgery and an immediate implant crown may demonstrate limited risk for advanced midfacial recession with less than 10%. Patients with a thin scalloped gingival biotype have been shown to be at risk for midfacial recession as reported in 2 studies. This may not be surprising because this biotype reflects the limited underlying bone support. As the buccal bone wall in these patients is predominantly built up by bundle bone that entirely resorbs following tooth loss and regardless of implant placement, midfacial recession may be a logic consequence. Zhou et al. In 2009 reported that among the causes of implant failure, the presence of a pre-existing inflammation from the adjacent tooth, which often resulted in retrograde periimplantitis, is easily neglected. An asymptomatic endodontic treated tooth may still have a chronic infection, which may be responsible for implant failure. Tilted implants, however, have been proposed as an alternative to axially placed implants in regenerated bone. Evaluation of survival rates of tilted implants was examined in a recent meta-analysis of 44 publications in which there was no significant difference in the implant failure rate or the marginal bone loss. Many placement errors arise when dentists have inadequate training in diagnosis, treatment planning, and proper surgical skills. The skill, knowledge, and expertise needed for implant dentistry require time, practice, mentoring, and an accumulation of didactic information. Inexperienced surgeons experience failures twice as often as experienced surgeons. In 1997, Lambert et al. Have shown that surgical experience with implant dentistry is related to survival at the second stage, especially for the first 50 implants placed. Often the first 9 cases have the highest failure rate. As one would expect, there is a learning curve that could contribute to implant survival rates. According to Gekali et al. In 2014, in a credentialed program the expected learning curve of the resident occurs with the 2-3 year length of the program and is controlled by the educational system and the experienced faculty in that program. A study conducted by the practitioners engaged in Applied Research and Learning Network, Da Silva et al. In 2014 has found that implant success is lower when implants are placed in a general dentist setting compared to those placed in an academic or specialty setting. A statistically significant odds ratio was found to be associated with high failure rates of implants placed by general dentists compared to specialists. Implant failure due to extra-alveolar position after the implant was placed by an inexperienced clinician without the use of a preliminary CT scan, which could have shown the severe anatomic concavity on the mandible. The cutting torque values for failed implants were lower than the corresponding values for survived stable implants. However, implants fail for several reasons. It is unlikely that a single evaluation of the local alveolar bone density can single out one of these reasons. A low torque value, in combination with other negative prognostic influencing factors, should necessitate extra checkups. There is suggestion that immediate and immediate delayed implants may be at high risk of implant failure and complications than delayed implant placement. However, aesthetic outcome might be better when placing implants just after tooth extraction. Both types of reconstructions influenced the clinical outcomes in different ways. None of the fixation methods was clearly advantageous over the other. Cemented reconstructions exhibited more serious biological complications, implant loss, bone loss greater than 2 mm, screw-retained reconstructions exhibited more technical problems. Screw-retained reconstructions are more easily retrievable than cemented reconstructions and, therefore, technical and eventually biological complications can be treated more easily. For this reason and for their apparently higher biological compatibility, these reconstructions seem to be preferable. In addition to poor bone quality, occlusal overload may contribute to higher failure rates in the maxilla. Esposito et al. Found that late failure of implants did not show any infectious factor. The combination of poor bone quality and overload compromises implant support and bone-to-implant ratio, leading to late implant failure. The number and position of the implants should be related to the amount of stress transmitted to the bone during either occlusion or parafunction as well as the bone density. Occlusal overload due to incorrect occlusal anatomy that led to excess lateral forces. There is evidence in the literature that patients with a history of periodontitis are at greater risk for peri-implantitis than patients without a history of periodontitis. It is important that periodontal disease is treated prior to implant placement. Since survival rates of implant treatment in periodontitis susceptible patients are still high, implant treatment is not contraindicated. As long as adequate infection control and an individualized maintenance program are provided. However, the higher incidence of peri-implantitis that is prevalent in these patients may jeopardize the longevity of the implant treatment. An increased incidence of implant failure and an increased prevalence of soft tissue problems have been reported in subjects with suboptimal levels of oral hygiene. These observations are consistent with the ones reporting an increased prevalence of complications following oral and periodontal surgery procedures in plaque-infected dentitions. A recent investigation has also suggested a possible synergistic effect of inadequate oral hygiene and cigarette smoking in the determination of marginal bone loss around successfully integrated implants. Systemic osteoporosis has also been mentioned as a possible risk factor for lack of success with osseointegration. Local rather than systemic bone density, however, seem to be the predominant factor. The effect of osteopenia on the survival of dental implants has been directly evaluated in a prospective investigation. This demonstrated that implants placed in lower quantities of bone were at higher risk of failure. Indirect evidence to support this notion also comes from the recognition that shorter implants present higher failure rates than longer ones in a given time period. Uncontrolled diabetes has been shown to be a risk factor for periodontal disease. A one-year report of implant survival in non-insulin-dependent diabetics indicated a 7.3% failure rate. This seems to indicate that zero CO integration can be obtained in the majority of diabetic patients. Nevertheless, the medium to long-term prognosis of implants placed in these subjects is currently unknown. Smoking has been associated with poor wound healing and adversely affects implant success rate. Early implant failures have been linked with smoking. In one study, 1 in every 3 early failures was in smokers who smoked 10 or more cigarettes per day. DeLuca et al. In 2006 reported that implant failure rate is significantly higher for smokers, 23.08%, versus non-smokers, 13.33%. Both early and late failures demonstrated a strong association with positive smoking history. Additionally, Krakonovik's literature review noted that 22 papers out of 27 listed smoking as having an effect on implant survival rates. Clinical application of the improving knowledge about the risk factors and indicators associated with implant loss and/or disease is urgently needed to improve and maintain over time the high success rate of dental implants. Knowledge of subject risk should assist the clinician with determining the prognosis for the individual case and thus with patient selection. Improved understanding of subject-based risk for peri-implantitis and biomechanical overload combined with a careful preoperative assessment of implant-based risk could be useful in determining number, location, and type of implants as well as the design of the reconstruction. Site-specific monitoring of periodontal parameters around implants will help with early diagnosis of marginal infection and ineffective monitoring of soft tissue health around these devices during the necessary recall appointments.